Welcome. My name is Blake Dodge, and I'm a healthcare reporter at Business Insider. I'm joined today by Dr. Ruchika Fernanda-Pole, the CEO and co-founder of Iora Health. Iora provides primary care and gets paid by health plans and employers on a monthly basis, basically to get costs down and make people healthier. I'm also joined today by Dr. Lori Zephyrin, the Vice President of Healthcare System Delivery Reform at the Commonwealth Fund, which is a sort of think tank and research hub for all things healthcare. Lori leads their work about inequity, payment, and policy reform. Welcome to you both.
Thank you.
As you both know, we're going to talk about how virtual care can address the many inequities in the US healthcare system. This is top of mind today with the coronavirus pandemic affecting some communities, namely Black, Hispanic, and Native American folks way more than others. My first question, Ruchika, is for you. Iora has dozens of clinics in 8 states for now. Tell us how you brought your members online throughout this pandemic, including those who had some kind of technological barrier.
So thank you, Blake, and it's good to be here. So as you said, we have about 50 clinics across the country. We serve largely low income and largely seniors. And then like everyone else in the middle of March, we realized we had to move a big chunk of our care from in-person care to doing it using technology, whether it's largely video. So we did. So we did literally on one weekend move from doing about 80% of our care in person to 8% of our care in person, and the rest by phone or video. This was really important for COVID, by the way, because it kept people safe. If we didn't have to see you in person, we shouldn't be seeing you in person. But by the way, it's also the right thing to do for these populations as well. And by the way, incidentally, for folks who are lower income at one end of the wage and the social scale, maybe virtual care makes even more of a difference, right? So if people who are wealthier and in white collar jobs can take days off to go to the doctor, people who are working in hourly wages cannot. Number two is just getting the doctor. If you've got to take 3 buses, et cetera, it's harder than if you could just drive to the doctor. So I actually think this is not a COVID issue. That's a red herring. This is sort of a general issue of how can we take this sort of technology that we're using today and allow everyone to do it, right? We should not be allowing the digital divide to make care more unequal. By the way, it's a very similar issue for education, right, where people are going to school with Zoom, et cetera. So we made a commitment. We're going to leave the practices open when we need to see people, but otherwise, we'll try and do things. And by the way, video is so much better than phone, right? We can make much better clinical judgments by video. We can build much better relationships by video than by telephone. So we should do that. It turns out when we started doing it, about 30% of our patients had some sort of a barrier to doing this sort of care for us, right? And that's sort of evenly split by people who didn't have a device, which had a camera and they could use it with, or people didn't have broadband access. And by the way, that's urban as well as rural. And then third is some sort of cognitive difficulty. It's worse for low-income people. So 36% of our low-income folks, as defined by on Medicaid as well as Medicare, had a barrier versus 26% of people not on Medicaid. It's a little bit by age, a little bit higher for people in their 90s and their 60s, but surprisingly not hugely. So then we put in place a bunch of programs of how do we fix this problem? And we tried a lot of things. We tried doing some visits and encounters on Saturdays where maybe a child can come and help them. We did where we tried to mail people tablets that were pre-configured. The one that worked the best, and we've done over several thousand of these, is where we have one of our health coaches from the community, with community workers, go to people's houses with a pre-configured tablet, hand it to them, sort of be the tech support, let them sort of interact with their doc who's back in the practice, and then take the tablet back and then put it aside. They do about 8 or 10 of these a day and then come back and clean all the tablets and go out the next day. By the way, why can we do this? We do it because we're in purely value-based payment models, so we don't have to worry about these sort of inane, do you bill for telemedicine or not? For us, if we can do this and keep people healthy and out of the hospital, we get paid for that, right? And that's what we can do. So what I feel really proud about is now we're doing today a lot of practices went back as quickly as they could to be doing in-person stuff. We didn't do that. We think we should keep a mix. So as of today, 40% of our encounters are in person, 40% are by video, 20% are by phone. We think that's the right number, and that's where we'll stay.
Right. Lori, to loop you in, I know you've been following this closely. What kinds of barriers to telehealth concern you?
Well, I think there's several barriers that I think are really important. We know that there are deep-seated inequities that have existed within our society for decades, that for generations really, that predate the pandemic. And so when we think about how the isms, whether systemic racism, gender oppression, or class oppression, how they influence policies that affect where people live, work, and play, we have to really understand that intersection and how that affects people's health, and also how people interact with the health system and how health systems interact with people. And telehealth is an extension of the health system, right outside of the four walls. And so Rushika mentioned the digital divide. And so when we talk about the digital divide, it's really people facing three overlapping barriers to accessing telehealth, whether it's lack of technology access, whether it's digital literacy challenges, or whether it's lack of access to reliable internet coverage. And so, if we think about digital literacy, how do we reach and engage diverse patients? How do we screen for digital access? How do we ensure that there are best practices for interpreter use? That's really important, and really having resources for that. Also, in terms of addressing barriers, what do we mean by digital inclusion? What we need real-time, day-to-day tools that address best practices in telemedicine, that can center equity, that address trust, that address bias, that address the best ways to communicate, and that makes sure that we're centering patient preferences. And then also when we talk about barriers relating to reliable internet coverage, we know that affects older people, people of color, those with low socioeconomic status. But, it's also important to understand how that happened. Whether we talk about, issues of redlining, there's, concepts of redlining of broadband. Companies can decide where to build broadband towers. And so, for example, our broadband tower is available in housing projects. And so it's really important to understand the barriers and understand the digital divide and how that interacts in urban communities and rural communities, and being able to build and extend telehealth solutions that invest and center equity.
Yeah, I'm excited to see the conversation evolve around broadband and internet as a utility. Like when we think about telehealth becoming critical and common, a critical and common way to deliver care. Lori, I'd like to put another question to you. You touched on how trust is kind of a key value here and needs to be important in the ways that we deliver virtual care. Can you talk about how healthcare organizations can be more anti-racist through the implementation of telehealth and other digital solutions? And Rushika, if you'd like to tune in afterwards, that would be great.
Great. I think that's a key concept. And as we think about addressing deep-seated inequities and addressing systemic racism and really thinking of how health systems can be anti-racist, there are a lot of health systems thinking about that right now and actually changing policies and practices to do that. And so telehealth is, again, an extension of that. It's not a separate siloed system. We have to think about the same type of anti-racist policies and values that we're applying to health systems that needs to apply to telehealth. The trust piece, Blake, is actually really very critical. We have to be able to engender trust. Discrimination and mistrust could be magnified in virtual encounters. And so how do we ensure that patients feel that they can fully communicate with their providers? How can we ensure that there isn't implicit bias based on attributes such as race or ethnicity or educational status? And do we know if the lack of a physical presence with digital care can compromise trust? So we do have to think about that. An interesting example, like at UCSF, they were testing out virtual visits before the pandemic as part of their San Francisco Respect initiative, which engaged families covered by Medicaid in designing new prenatal care models. And what's really exciting about that model is that they were engaging the families in the design of these models. And some of the providers, what they were able to find during those visits, they were able to connect with their patients and connect with the women in a very meaningful way, be able to gauge their mood, pick up cues, get a sense of their surroundings. And so we need to understand more about that and do more to build trust and make sure that extends to telehealth.
So just to add to that, so I actually think telehealth is a red herring. It's actually health, right? So we need to actually take care of people's health, and telemedicine is just like a part of that. The proposition of IORA is that relationship matters, that healthcare is actually a really important thing, and we need to do it in the context of trusting, healing, ongoing relationships. So I think that one of the directions we're going with telemedicine, where there's a separate company and some random doc you've never seen before is trying to do this, it's separate than your usual care. I think that's a bad idea. Again, sure, if you don't have any other option, fine, but it's not the ideal state. The ideal state is you have a trusted team of people who are taking care of you, that you have put your trust in, and that we are able to engage with you in a variety of ways. When it's the right thing to do, have you come in person, we'll see you in person. But if the right thing to do is see you by video, we'll do it by video. And by the way, or we'll do a text message, it's a multi or omni-channel way. To Lori's point, we've been doing this a long time. Sometimes you actually get more information from a video chat with the patient than an in-person visit. You see their surroundings. You have their family members join in. They can introduce you to their dog, right? Things you can never do in the office. So people come to the office, they all look great. They put some makeup on, they dress up, and you don't see their setting, right? So, but yet there are some things that are much better done in person, right? There are important conversations. I think relationships are better built in person. I think there's some clinical things which we just need to lay hands on people. So the answer is both. It's in the context of a relationship. And I think you have to build a whole system around that. And I think particularly when you deal with racial issues, that makes a difference, right? So it's everything, right? So this is got to be rocket science. Make sure our teams are reflecting, racial sensitivity and to be honest, reflect the race of people they have. So IORA, we think is really important. So we make sure that our teams reflect the racial composition of the people they're serving. And you've got to do some work to do that. You've got to make sure that they're trained well. You've got to make sure that you do these, but it's all in the context of a relationship.
Mm-hmm. Yeah, thank you both. I think when we're talking about inequity in healthcare, another really important issue is cost. Last week, a former colleague of mine at Bloomberg, Drew Armstrong, asked the CEO of Amwell, basically if telehealth will be like all the other healthcare innovations we've seen, where instead of driving costs down for everyone, they create another revenue stream for companies. So Rishika, maybe you go first on this one. Do you think telehealth will make healthcare cheaper for the people who really need it to be cheaper?
So I don't think inherently it will, to be quite honest. This is maybe a radical thing, again, because there's no such thing as telehealth. It's about health. Let's design ways to deliver healthcare to people in ways that are better for them, better experience, and lower cost. Simply, this is why sort of just layering telehealth on top of the current system is almost certainly not cost effective. It just adds a layer. It needs to be designed in the context of the system. But another piece is, there's a lot of talk about digital health. Digital health and telehealth are two different things, right? Simply taking a doctor visit and putting the doctor on a video doesn't really do very much at all to lower costs. Unfortunately, the expensive part of it is us, the doctors, right? Who cares about the other part? I think there's a whole lot of ways we can redesign healthcare to lower costs. And that's really about engaging people, using some of these digital tools to make sure people, track what they want to track, et cetera. And that's what we need to do, not simply the unimaginative thing of throwing it on video. Really simple example, the way we manage a chronic disease now, like hypertension, we see someone in the office, I'll see you back in 3 months or in a month, and I'll take your blood pressure. And if you do that by video versus in person, it doesn't really lower the cost. What we really ought to do is tell someone, here, give them self-efficacy, here's a cuff, measure your blood pressure, send me the results. As long as it's doing fine, you don't need to see me, go about your life. Only when I think you need it. Now we're going to activate the conversation, right? That saves money in healthcare, not just substituting a few visits for telemedicine.
Well, and I have some appreciation for the way you guys communicate with patients about their blood pressure, right? They can text you, call you, video you, depending on their preference and access to technology.
Yeah, and that's important, right? We need to be designing these around the patient, not ourselves. So too often, and again, no offense to our Silicon Valley friends, they come up with an app and now everyone's got to use their app. That's not the right way to think about it. What's the need? Is I need to get my blood pressures to my doctor. Now let's design a variety of ways to meet people where they are to do that. If they can use the app, that's great. If they aren't able to use an app, is there another way they can do it, right? So let's have a variety of things designed from the consumer up, not the app down.
Right. I think to add to that, to your point, you really have to center the person and center the patient and create the model, right? So right now, the payment incentives will drive the model. I mean, not in your model, Rashika, but we may have we see more people coming back to in-person visits because people want that revenue stream. But is that, for example, what patients want? There was a question in the chat about, access to women's health, for example, or maternal health. I mean, I think an example sort of in my clinical practice, if there are no-shows, it's not because women don't want to come in for visits, but to make the choice between working and supporting their family or coming in for a visit, the former would prevail, right? In our current work at the fund, we spoke to providers in the maternity space in rural areas, for example, and some women had to drive 3 to 4 hours each way for a visit, spend $50 to $100 on gas or childcare. And so they need little convincing that telehealth was a good idea. And so really for those examples, if we're centering in this example, the mom or the person, then we would say telehealth is a great idea. We want to invest in that. That can potentially decrease costs down the road in terms of less morbidity, less mortality, better long-term outcomes. However, if we just say now everyone has to come back to an in-person model of care, that doesn't necessarily center the person. And so to Rashika's point, it's really important to think about what's the care we're trying to deliver and how is that increasing value and decreasing cost.
Mm-hmm. One of the questions, it looks like we've got about 5 minutes left, so bear that in mind. But time flies when you're having fun. There's a lot of different kinds of telehealth vendors out there. Like there's the Teledocs of the world. They work a lot through employers and health plans. There's the Amwells of the world. They tend to set up tech for health systems in addition to doing their own visits. And then there's DoxyMe, which I know Iora uses for visits, which is a pretty small, lean operation, all things considered. What do you think, like which telehealth will prevail at the end of the day? Like Rishika, do you think it's going to be the telehealth that's very specific and dynamic, or do you think it'll be do you think it'll be the telehealth vendors that do one thing very well, or do you think it'll be the telehealth vendors that tend to try to create a big solution, like a big plug and play solution?
Yeah, so again, I feel like a broken record. I don't think there's such thing as telehealth. It's like asking, I want to start a telephone health company. Like, of course you wouldn't do that, right? We're going to build a health company. We're going to center around meeting the needs of a population, and we're going to use the right tools to do that. So again, we're big fans. So the vast majority of, quote, telemedicine or telehealth companies today are really tele-urgent care companies. What they do is you're essentially a young, healthy person. You call these people up. They have not the foggiest idea of who you are. They have no records about you, and you tell them something and they tell you what to do, and then you go about your way and you'll never see them again, right? I mean, I think that's fine for some set of needs. That's not the big problem in healthcare. The big problem in healthcare is chronic disease. It's ongoing relationships, how to improve people's health. And I think what's going to happen eventually, the reason these telehealth vendors by and large exist is because the doctors have fallen asleep at their switch. They're too stuck in their payment models, and they're not meeting the needs of their customers, their patients, because they're refusing to actually engage with them by video, right? So when they finally wake up and do it, now do they need vendors to help them with the piping and the stuff? Absolutely. But again, I think the vast majority of people, put the really young, healthy people aside, would rather get their health care from someone they know and trust, and they may have met at least once and knows their records and, you know, speaks their language and, you know, all of those things. So again, I think the industry has grown up because of a set of needs, largely because the existing providers have fallen asleep at the switch. And I think that will change over time.
All right, well, thank you both for joining me. It's been a great, complicated conversation that needs to be had. I really appreciate it. Thanks for your time.
Great.
Thank you.
Thank you.